Welcome to part 4 in our 5-part cancer genetics CME series titled Updates in Cancer Genetics, Personalized Treatment, and What You Need to Know from Oncology. I'm pleased to welcome our speakers for this session today, Dr. Nina Tan, Dr. Marianne Dubar-Gault, and Dr. Bruce Montgomery. Our learning objectives today will be to apply updates and personalized treatment related to breast cancer and genetics, explain updates and personalized treatments related to colon cancer and genetics, integrate updates and personalized treatment related to gynecologic cancers and genetics, and provide updates and personalized treatment related to prostate cancer and genetics. Continuing medical education is available for watching these recordings. If you are watching this recording in a group setting, please make sure you register for the webinar and complete the evaluation as an individual so you can receive CME credit. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the Federation of State Medical Boards, the Washington State Department of Health, and the Washington Medical Commission. The Federation of State Medical Boards has designated this enduring activity for a maximum of 1 AMA PRA Category 1 credit. Full disclosures for all of our speakers and planners are available on the Washington Medical Commission website. This webinar is not funded by any commercial entities. Our speaker disclosures are included here. All relevant financial relationships have been mitigated for this presentation. And with that, I will turn it over to our first speaker, Dr. Nina Tan. Thank you.
All right. Hi, my name is Nina Tan. I am a physician at the University of Washington and at the Fred Hutch Cancer Center. I'm an internist, mostly primary care, but also work in our breast health clinics and our breast and ovarian cancer prevention clinic. I will be talking about high risk and hereditary breast cancer today, and some pearls for management for the primary care physician or primary care provider. So objectives for our talk today, we'll identify individuals who are at high risk of developing breast cancer. We'll identify individuals who may carry a pathogenic or likely pathogenic variant associated with breast cancer. We'll interpret genetic test results, and then we'll counsel high-risk patients on recommendations for screening and risk reduction for breast cancer. And just a side note, throughout this talk, I may use the term woman or women and use she, her pronouns to describe individuals assigned female at birth. So breast cancer is common. In the US, 1 in 8 women will be diagnosed with breast cancer in their lifetime. So about a 13% lifetime risk of developing breast cancer. And most who are diagnosed with breast cancer actually do quite well. We have relatively good screening and management options available for breast cancer. According to the National Institutes of Health Cancer Epidemiology data, the 5-year survival rate for breast cancer is about 91%, as you can see on the slide here. And that's among females across all ages, ethnicities, cancer subtypes, and stage of diagnosis. Most breast cancer is sporadic, meaning there is not an associated hereditary cause, and any DNA damage or mutation is acquired during one's lifetime. And so that's about 70 to 80% of breast cancer cases. About 5 to 10% of breast cancers are secondary to an inherited germline pathogenic variant in a cancer-related gene, such as a mutation in BRCA or PALB2, genes that are involved in DNA repair or tumor suppression. And then about 15 to 20% of breast cancers are familial, meaning the disease occurs more often in family members that can be expected more often family members than can be expected in the general population, even though there hasn't been a particular gene mutation identified in a family. So with familial breast cancer, the specific cause of breast cancer is really unknown, but most likely due to a combination of risk factors, including possible genetic variants, lifestyle, and environmental factors that increase risk in that family. Risk factors for breast cancer can be categorized as non-modifiable and modifiable. So of course, age is one of the strongest risk factors for cancer in general, because over time there is more damage to DNA. And that's why we see that most cases of breast cancer occur after the age of 50. Age of menarche and menopause also are related to breast cancer risk. So menarche before 12 and then menopause after 55. Not having any pregnancies is also associated with a higher lifetime risk of breast cancer. And not breastfeeding also is associated with a higher risk of breast cancer. And that all has to do with hormonal exposure over a lifetime. Some of the modifiable risk factors include exercise, daily activity, alcohol use is more strongly associated with breast cancer as well, and then exposure to different hormonal medications throughout a lifetime, such as menopausal hormone therapy or combined birth control pills. And there are different reproductive, hormonal, and family history risk factors that are associated with different relative risks of breast cancer. And so a few things to emphasize here, as you can see in this chart, first-degree relatives with breast cancer do confer a higher risk of breast cancer for an individual. However, so do second-degree relative breast cancer history cases. And so that's why it's important when we're talking with patients to get, at least a two-degree relative family history, if not up to third-degree relatives as well. And other strong risk factors include therapeutic radiation to the chest at a younger age, hereditary mutations, which we'll talk much more about in a minute here. And then if the patient themselves have ever had a prior breast biopsy that has confirmed an atypical lesion, such as atypical ductal hyperplasia, these are things that can increase risk to quite a higher degree compared to the general population. And formal risk assessment for breast cancer includes estimating breast cancer risk using risk calculators. And so there's various risk calculators out there. The two that I use most commonly are the NIH Breast Cancer Risk Assessment Tool, which I typically use for patients who don't have a strong risk factor for breast cancer. And then on the other hand, if a patient has 2 or more family members with breast cancer, or they had a history, a personal history of an atypical breast lesion, then I will use the Tyrer-Cuzick or the IBIS risk calculator, which more comprehensively takes into account the family history. And we won't be discussing these risk calculators in detail today, but there are many resources and papers available that discuss how to use these calculators. And then referring your patient to a breast specialist or a breast clinic, they can also do this estimate for the patient. So the estimated risk of developing breast cancer can then be stratified into average risk, intermediate risk, or high risk. So those who have a 5-year risk of 1.67% or greater, or who have a lifetime risk of 20% or higher, are considered to be at higher risk of developing breast cancer. And this is important because for those who are considered high risk, there are more aggressive screening and risk reduction recommendations. And we'll talk about these recommendations towards the end of the talk here. So our next objective is to identify individuals who may carry a pathogenic or likely pathogenic variant associated with breast cancer. And so when do we consider hereditary breast cancer when we're talking with our patients about their family history? As we mentioned earlier, we want to ask not only about breast cancer history in first, second, and even third-degree relatives, but also to talk about just all cancers in general, because there are these hereditary cancer syndromes where we might see different types of cancer appear in different people, but they're all linked to a specific hereditary mutation. So the important information to ask patients is what types of cancers have come up in the family, how the family member is related to the patient, and the age or decade of diagnosis. Often, but not always, cancers associated with an inherited pathogenic mutation may present earlier in life. So for example, there may be a pattern of premenopausal breast cancer noted in a family history, even though generally we see that breast cancer typically occurs after menopause. So there are a couple of different tools that are out there that you can use to help determine if a patient's family history is suspicious for a possible hereditary cancer. Some of them are listed here and can be found on the CDC website. One example that I have up here is this referral screening tool. which asks questions about both maternal and paternal history. And if 2 or more are checked, then this prompts a recommendation to refer to a genetics clinic for further evaluation and possible genetic testing. The National Comprehensive Cancer Network also has guidelines outlining when to refer a patient for genetic testing. There are criteria for those who have a personal history of breast cancer and for those who don't have a personal history of breast cancer, but maybe they have a family history of breast cancer. So in those who have a personal history or diagnosis of breast cancer, if they meet the following criteria, so diagnosis under the age of 50, if it's a triple negative breast cancer, if there are multiple primary breast cancers that occur at various points in their life, if they are assigned male at birth, if they have Ashkenazi Jewish ancestry, or if they have lobular breast cancer and a history or family history of diffuse gastric cancer. These are reasons why we would recommend referral to genetics clinic for consideration of genetic testing because they are at higher risk of having a hereditary mutation. And then additionally, if someone has a personal history of breast cancer, but they don't quite meet that criteria that we just discussed, but they do have a family history that meets this criteria outlined here. So for example, if there's a first or second or third degree relative diagnosed with breast cancer under the age of 50, a male who had breast cancer in the family, if there's a relative with ovarian or pancreatic cancer or metastatic prostate cancer, or if there's multiple of each of these cancers on the same side of the family. Again, this is more suspicious for a possible hereditary cancer syndrome in the family. So if a patient does not have a personal history of breast cancer, and we're just going off of family history, we're looking at history of their first and second degree relatives. And if those relatives meet any of these criteria that we just talked about again, so earlier age of diagnosis, multiple primary breast cancers, if there's a family history of ovarian or pancreatic cancer as well, etc. These are again reasons to recommend a referral for genetic testing. I also want to make a quick note about male breast cancer. Male breast cancer is extremely rare in the general population. So if there is a male patient who is diagnosed with breast cancer, it's recommended that they are offered genetic testing, since there is a higher chance that male breast cancer will be associated with an inherited genetic mutation. I also want to highlight that it can be a very personal and complex decision for a patient to pursue genetic testing. And as with anything in medicine, we can offer or recommend patients the option of getting genetic testing, but ultimately it is their choice. And there are also non-medical related considerations. So for example, there is a federal law, GINA, the Genetic Information Non-Discrimination Act, that prohibits health insurance companies from using genetic testing results in enrollment or coverage decisions. And it also prohibits employers from using genetic information in employment decisions. However, GINA does not apply to other types of insurance. So for example, life insurance, disability insurance, long-term care insurance. And I've worked with patients who have decided not to get genetic testing for this reason, among many other personal reasons. So how to go about ordering genetic testing. So when a patient is interested in testing, most major health systems will have genetic counselors or a genetics clinic. And there are also these direct-to-consumer genetic testing companies. And most all of these places will have access to a genetic counselor who can do a pre-test visit to help patients decide whether and which specific test or panel of tests would be appropriate. Genetic counselors are well-versed in interpreting family history and deciding which genes or gene panels to order. So they can offer both pre-test counseling in terms of discussing what are the possible results, making sure to document consent, and then they can also do post-test counseling to help interpret the results and recommend any next steps that might come up for screening and management. Generally, it is most informative for the family member with cancer to get genetic testing. And sometimes a patient will share that their family member has had testing and, for example, didn't have a BRCA mutation. But we just want to make sure that there was more comprehensive testing done than just BRCA mutation testing, because especially in more recent years, as technology has advanced, there are more and more genetic mutations that are identified that can be associated with an increased risk of breast cancer. So we'll talk about how to interpret genetic test results. And I'll just go over this really briefly. Generally, most academic organizations and companies will use this sort of 5-tier system of categorizing variants that can come up. And this is established by the American College of Medical Genetics. And so for variants that are considered to be of uncertain significance or likely benign or benign, those are all actually treated the same clinically. They're clinically very similar. Variant of uncertain significance is one that can cause some confusion, but it basically indicates that at this time, there is insufficient or conflicting evidence about a variant's role in disease. And then for variants that are considered to be likely pathogenic or pathogenic, these are mutations that have been associated with an increased risk of a disease, and again, are clinically managed in the same way. So likely pathogenic just means that the variant most likely has a harmful effect, but doesn't quite meet the criteria for pathogenicity. And so typically interpreting a genetic test result is pretty straightforward. Each company has sort of their own layout, but the results are typically on the first page. So a negative result means that there were no variants, pathogenic variants identified. So in this case, you can see that the report shows that there were 83 genes that were looked at, and there were 2 variants that came up. One was in the BRCA2 gene and another was in the PALB2 gene. And so here we see that the variant in the BRCA2 gene was considered to be pathogenic, so associated with a higher risk of various cancers, including breast, ovarian, prostate, melanoma. And then the PALB2 variant was a variant of uncertain significance. So again, because this particular variant has not met criteria to be classified as pathogenic or likely pathogenic, it would be clinically managed as if it's benign. And so risk of developing breast cancer will vary with each pathogenic or likely pathogenic variant. So for example, those who have a BRCA1 gene, the estimated chance of developing breast cancer by the time they're in their 7th decade of life is thought to be about 55 to 72%. And for BRCA2, it's thought to be about 45 to 69%. And these variants can be further classified as high penetrance versus moderate penetrance. Variants that are high penetrance means that there's a higher likelihood that someone who carries that particular variant will develop disease. And some examples of those high penetrance variants are seen here in this table that is taken from our National Comprehensive Cancer Network, or NCCN guidelines, that show the estimated lifetime risk of upwards of like 30 to 40%. Whereas for moderate penetrance variants, these are variants that are associated with a more modest degree of cancer risk, generally relative risk of about 2 to 5. And so you can see some examples here again. CHEK2, RAD51, most ATM mutations are in this moderate penetrance category. So lastly, we'll wrap up by talking about how to counsel high-risk patients on recommendations for screening and for risk reduction. So with breast cancer screening, just to give a broad overview of high-risk screening recommendations and how it differs from average risk recommendations. So you can see here that with average risk, the recommendation is really to use screening mammograms as the backbone of screening and to talk with patients about what types of symptoms or signs they should be looking out for. When we get to high risk, and so this is again going back to that lifetime estimated risk of 20% or higher, or if someone has a known pathogenic or likely pathogenic variant, then we're much more aggressive about screening. And so we recommend not only screening mammograms annually, but also annual screening breast MRIs, as well as clinical breast exams anywhere from every 6 to 12 months, in addition to the breast self-awareness. And so again, these guidelines can vary based on the variant that's found. And so, for example, in females who have BRCA1 or 2 high penetrance variant, by the time they're 18, we want to make sure that we've counseled them on breast changes to look out for: dimpling of the skin, puckering of the skin, nipple inversion, nipple discharge, things like this. And then at 25, the recommendation is to start annual screening MRIs and clinical breast exams, again, every 6 to 12 months, and to continue that until the age of 30, when annual screening mammograms are also incorporated into this recommendation. And that continues up to the age of 75 when we start to make sort of shared decision. We sort of have shared decision making about whether or not to continue screening, just based on sort of generally how we talk to patients about screening. And then for breast cancer screening in males with BRCA1 and 2 mutations, so by the time they're in their 30s, we want to make sure that, again, that they've received counseling on what are the signs and symptoms to look out for, making sure that they're getting an annual clinical breast exam, whether that's with a breast center or with their primary care providers. And then by the age of 50 years old, or 10 years prior to the earliest known male breast cancer diagnosis, whichever is earliest, is when we would start annual screening mammograms. And then for these more moderate penetrance variants, so for example, variants in CHEK2, the age of diagnosis for screening will vary based on the variant. And based on epidemiologic data that's been collected about each individual variant. So you can see here that with CHEK2, the recommendation is to start annual screening MRIs about 30 to 35 years old, and then at the age of 40 to incorporate the annual screening mammograms up until the age of 75 again. And you can find all these guidelines in the NCCN hereditary cancer guidelines, which discuss when to start screening for different variants, when you would start mammograms versus MRIs, whether or not there are other recommendations for management. And then lastly, for breast cancer risk reduction, we'll just talk about this briefly. There are day-to-day things that patients can do, which just sort of encompass those healthy habits that we try to counsel and recommend, including just living an active lifestyle, making sure to incorporate daily activity, trying to minimize alcohol, generally to no more than 1 drink a day for women or 7 drinks in a week, but really, trying to minimize to even less than 3 drinks a week if possible. And then there are also risk-reducing medications that we can recommend for patients who are at higher risk of breast cancer, sort of with some nuances here, and especially when it comes to some of these hereditary breast cancers, where there hasn't necessarily been strong data showing that these things might be effective. And then lastly, there's also risk-reducing mastectomy, which we'll talk about as well. So general overview for risk-reducing medications. Prior to menopause, tamoxifen is the only option. And after menopause, we have both tamoxifen and raloxifene, which are very similar. And then aromatase inhibitors is another class of medications. And with these medications, taken every day for 5 years, it can reduce the risk of breast cancer by about 50% in general population studies. Some of the caveats for hereditary breast cancer, though, are that there's really unclear efficacy in these there was one study that was done a while ago that showed that for those who had a BRCA2 mutation who took these risk-reducing medications, there did seem to be a decreased risk of breast cancer. But this was a very, very small N or number of cases within a much, much larger study in a subgroup analysis. And it is also thought that though the genetic mutations that might have a predisposition to an ER-negative breast cancer may not actually benefit from risk-reducing medications, since these do work on estrogen receptor activity. So for example, BRCA1, BARD1, RAD50, RAD51C and D mutations, et cetera. It remains to be seen whether or not these medications would be truly effective in reducing risk of breast cancer. Risk-reducing mastectomy is our most effective risk-reducing tool and can reduce the risk of breast cancer pretty reliably by at least 90%, if not closer to 95%. And so this is often discussed with individuals who carry those high penetrance pathogenic or likely pathogenic variants. Evidence is really insufficient in many moderate penetrance variants, so such as CHEK2, and generally the recommendation is to manage this based on family history. So for example, if a patient has a moderate penetrance variant and has a really strong family history of breast cancer, maybe in like 2 or 3 or more relatives on the same side of the family, that is a situation where maybe it's worth talking with a breast surgeon about the possibility of risk-reducing mastectomy. And different institutions probably have different cutoffs in terms of level of risk that breast surgeons would be willing to offer a risk-reducing mastectomy. So it's worth getting to know what those thresholds might be for your institution. And before we wrap up, I just want to leave you with this important counseling point, which is that on a population level, hereditary breast cancers do not have a significant difference in overall survival or cancer-specific mortality compared to the general population, which is often good news for our patients who have these hereditary mutations. So thanks so much for your time. This is my email address. Feel free to email me with any questions. Happy to be a resource for you. Thanks so much.
Hi, my name is Marianne Dubargault. I am the medical director for high risk and cancer genetic services at Swedish Cancer Institute in Seattle. And my tasks today was to give you specific updates in GI or colorectal and gastric cancer for genetic predispositions, and also in GYN or gynecology for the same for genetic risk of cancer. So we'll talk a little bit initially with on colorectal cancer types of things and updates, and then we'll do the GYN or gynecology piece next. All right, so briefly on patients with early onset colorectal cancer, really just a few words there. And then we'll do a little bit on polyposis or patients with a polyposis syndrome and what to think about it for them then, because genetic testing would be very useful to identify who needs the most amount of screening and different types of polyps patients can have, who doesn't need as much screening. And we'll see, like in the family, some patients may not need as much screening, and the kind of interval or frequency in between colonoscopies for these patients. And then we'll talk about the main topic for colon cancer or genetic predispositions to colon cancer. That's Lynch syndrome with a lower burden of polyps, but still some polyps, and in a multi-organ predisposition, really, and patients presenting with mismatch repair deficient types of tumors. And we'll go in details about what that means. And I'll touch on aspirin a little bit as well. So patients with early onset colorectal cancer, I'm sure you've seen it in your clinic. Many, many young patients now are developing colorectal cancer between 25 and 40. Even in my clinic, actually, I've seen 19 and 20. And most of the folks we test genetically return negative, telling us two things. Either one, they have a genetic risk that we cannot identify today, so we have to keep them in mind and test them later, and or that there's an exposure to environmental factors or other things that we're not aware of or catching today. And what I think really is happening is probably a combination of both of these things. So today, that's all I'll say about early onset colorectal cancer, but there's probably a lot more for us to do on research and learning about the colorectal cancer for these patients. All right, so briefly on familial adenomatous polyposis, FAP, I'll use that from now on because it's a mouthful. And so this predisposition has the highest risk of colon cancer for patients. And you've probably learned about this in medical school. We see patients developing colorectal cancer in their 30s usually, and then before that they have the carpet of polyps or hundreds of polyps in their gut. They also can have upper GI cancer, so duodenal cancer more than gastric cancer, although they can get both. And we add upper endoscopies types of things. I'll talk about that in a second. And they can also have other types of cancers, thyroid cancer, the cribriform type from medical school, brain tumors, medulloblastoma specifically, and for infants in the family, hepatoblastoma. So if you hear that, that should be a flag to refer these patients for genetic testing, because hepatoblastoma is pretty rare. And I put there the telltale signs of things you can look for patients in your clinic or relatives in the family to identify these patients, although these days we go straight to genetic testing. So I don't use these markers as much. They're good to know, but I don't use them as much to test patients. And we test patients really early, mainly because we start the management as soon as possible for these families. So colonoscopies would start usually around the age of 12, between 10 and 15. And every year or sometimes every 6 months if the burden of polyp is much greater. Sometimes if we don't need to, we can extend the colonoscopy schedule to 2 to 3 years initially, because kids are still quite young, until they get to a larger number of polyps. And then as soon as the polyp starts on the lower gut, we do the upper endoscopies. That's usually the sign to go on the upper side. And we do the side view mirror, because the duodenal cancers are harder to see with the tube alone. So we have to have that side view mirror to look at the duodenal side and the ampulla. And then if the polyp burden becomes unmanageable with endoscopy, we refer patients to surgery. And you see the different types of surgery there, keeping in mind that sometimes these patients still need flexible sigmoidoscopies or other types of screening from the lower gut, because they've kept a piece of their rectum or something that has a high risk of polyp still, or cancer. So they may still need to be screened. And then to keep in mind, we tend to stay very minimal in recommending or doing surgeries in these patients, because they can develop these large desmoid tumors, and those desmoid tumors occur usually at the site of surgery, or where people stapled, or at the site of healing laparoscopically or laparotomy. And so these large tumors can really impact compressed organs or impact GI function quite a bit. So we tend to be as minimal as possible. And there's no really FDA approved therapy yet that has panned out for patients with FAP, but hopefully soon there will be some. Other polyposes briefly, the only one that's recessive for you to know or keep in mind is the MAP, and that's MUTYH associated polyposis. It's recessive, so you need 2 mutations from both sides of the family to have a patient with this genetic predisposition. And it matters then for the siblings of this patient, not necessarily other relative in the family, but the siblings, because they also may need intensive management for their polyposis, because they would have a higher risk of developing polyps and cancer. And so we follow a similar protocol as for FAP, although we don't do the thyroid and the other parts of the body. We focus on the GI tract. And it's also really important for the relatives, because having 2 mutations means you have MAP, but having 1 mutation alone, either on one or the other side, doesn't necessarily mean that there is a significant risk of colon cancer. It's actually not that much increased. And so for these relatives, we don't need intensive screening. We need just a bit more reassurance to make sure that they're covered for their colonoscopies, but not the same as their relatives. The other polyposes you see there, I won't spend too much time on that. And then for the juvenile polyposis, I wanted to mention the one that would be important for you to know or remember, because it's an overlap condition between a polyposis condition and arteriovenous malformation condition, hereditary hemorrhagic telangiectasia, HHT, which was called also Randu disease before, but now HHT. And so that condition with a mutation in the gene SMAD4 is really important to remember, because we have to surveil their GI tract for polyps, and we have to follow other organs like the heart and lung for those AVMs, the liver for the malformations, and the brain because of their risk of bleeding. And so there's a protocol that includes the GI tract and all of these other organs for management for HHT. And I put the guidelines there for the international guidelines for HHT, Cure HHT. So that's a document that's updated every other year, I think. And so that's a very good resource to have. Other polyposes briefly, Cowden syndrome, or now called PTEN, P10 hamartoma tumor syndrome, or PHTS, because it's a spectrum of conditions, not just one. Just for you to remember, this is a multi-system type of condition with multiple other problems, but in the clinic, they can show and have a goiter, they can have lipomas or vascular malformations, and they can have a really significant risk of cancer of the thyroid, the breast, the uterus, and the kidney. So they need a multi-organ predisposition, multi-organ screening type of protocol, because they have a multi-organ type of risk. And so I'm one of the doctors in the state of Washington and a few other states where I can help put this protocol together, so we cover all of the organs for these patients. And you see one of the patients here, Caitlin, who shares her journey with Cowden syndrome for her on YouTube, so you can watch her videos. And then Peutz-Jeghers, much rarer than the other conditions, but one to keep in mind because it comes with a significant risk of cancer. Actually, pancreatic cancer is the highest. So that's one of the predispositions to pancreatic cancer. breast, colon, and stomach cancer as well. And what's important is because it's a polyposis, these patients develop large polyps. Sometimes they're 3, 4, 5 centimeters, and they can twist the small bowel, or they can make the small bowel intertwine, and that causes a risk of intussusception for patients with this condition, even in adulthood. So they need to have either a letter in their wallet or medical alert bracelets to make sure that their ED doctor is aware that they can develop a condition of childhood. And then also I put the picture there for you to see those papules that you find or that are signs, they fade with age. So if you meet someone who's 48 or 50, they may not have the same type or coloring of their macules as they did when they were 18. So keep that in mind as well. All right, most importantly now, because this is the most important one I want to share with you today, is Lynch syndrome, right? So Lynch syndrome is really common. The Department of Health of the state of Washington estimate that about 20,000 people in the state of Washington have Lynch syndrome, and the majority of patients don't know they have Lynch syndrome. So there's a lot of work for us to do to identify these patients. It's a genetic predisposition to repairing mismatch repair errors in the DNA. So when there's a mistake, this polymerase slips on this microsatellite sites and it doesn't get corrected appropriately. And that's what creates those mutations and this microsatellite instability. And you see there the slippage, or the picture of the slippage of the polymerase. And so that's what the genetic condition is about. It's a multi-organ predisposition, so it affects multiple organs of the body. We didn't know this as much 10, 15 years ago, but now it's very well defined that it's more than colorectal and uterine cancer. When we do screening for this condition, we use a stain. So we stain the tumor, colorectal cancer, uterine cancer, with a stain. So we get the slides, we put the stain on, and we look for these mismatch repair proteins. And if they're missing, it's a sign to say that maybe this patient has Lynch syndrome, but it's not confirmatory. So the patient always needs to be followed up on and have hereditary cancer genetic testing to confirm they have Lynch syndrome, because there are other reasons why people would have a mismatch repair protein missing in their tumor that may not be Lynch syndrome. So you want to do the initial step to identify these patients and the follow-up confirmation to give people a diagnosis of Lynch syndrome. So this is an example. So you have here a picture of what staining with IHC or immunohistochemistry looks like for a patient with uterine cancer. So the panel A in blue, all the blue colors, is really this MSH6 protein missing. And you can tell between the blue and the brown, there's a lot of brown. So the other proteins are there, and the blue or the MSH6 protein is missing. So this patient would be eligible to have genetic testing for Lynch syndrome and would have a MMR deficient type of uterine cancer and may be eligible for therapies that are specifically more effective in MMR deficient tumors. So you could do the MMR deficiency testing with IHC or staining, or you could do it with the large scale, either PCR testing or large scale sequencing with next generation sequencing, for example. And you can see there on the other side of the slide, this MSI result, or this microsatellite instability picture, where you see between the normal and the tumor has a lot more slippage, or this polymerase just like really hiccuping and creating these mistakes. So then you classify whether the tumors are high in microsatellite instability, MSI high, intermediate, or stable, or people say MSS. And so that's very useful because this has been done for many colorectal cancer, uterine cancer, and many other cancers now. And when people did this type of testing, they found that these proteins, these mutated proteins, were immunogenic. So they really had a lot of infiltrating lymphocytes in those tumors to try to attack the cancer. And they used that mechanism. They leveraged this mechanism to develop immunotherapy. And that's why now there's been maybe now 6 or 7 years ago, we've had a kind of FDA granted approval for many therapies to leverage this mechanism where immunotherapy would work for these patients. And so this is true for colon cancer. This is true for many other cancers too. This is an example here of multiple cancers. This is Dr. Latham et al. At Memorial Sloan, where they tested thousands of patients with cancer, and they tested for their MSI. And if you see in green here, all the green dots are telling us this is a high score for the microsatellite instability, saying these patients would benefit from maybe immunotherapy. And so it's more than colorectal cancer and endometrial cancer, as you see, urothelial, small bowel, many other cancers out there. On to the risks for Lynch syndrome. So when you have Lynch syndrome, especially the high-risk Lynch syndrome, which is MLH1 and MSH2, patients have an earlier onset type of colorectal cancer predisposition. So colon cancer the risk starts in their 30s or 40s, which is why we start screening sooner. And the risk is 10 times the general population. So if the general population's risk is 4% lifetime, the risk is in the 40%, so 10 times the risk than everybody else. I put this table comes from the NCCN guidelines. So you have the guidelines at the bottom, and you can click on this link to access those guidelines, and they're updated every 6 months or so. MSH2 is the same or similar to MLH1, also a really high risk of colon cancer and a high risk of ovarian cancer. We'll talk about that in a little bit. And then other cancers, gastric cancers, pancreatic cancers, gallbladder and other small bowel cancers. And then for MSH2 specifically, maybe an increased risk of urothelial, or the lining between the kidneys and the bladder, urothelial cancer, as we've found recently. MSH2, maybe more than the others, have an increased risk of these cancers. So what do we do for patients who have these high-risk Lynch syndrome? So the mainstay really of screening is colonoscopy. And the colonoscopy schedule starts early, usually 10, 15 years prior to when their risk is high. And so 20 to 25 for the first colonoscopy, sometimes sooner if there is an earlier onset cancer in the family. And then we repeat it every other year up until the age of about 40, or if the polyp number is high enough that they need to be screened sooner, and then it's annually after that. And we do this because there is a faster sequence between the polyp and the cancer development in Lynch syndrome, so we match the interval colonoscopy based on that. Upper endoscopies are added also because of the upper GI cancer risk, usually between 30 and 40. And we tend to repeat them between 2 and 4 years, either based on the family history or personal history of Barrett's esophagus, for example, or the gene mutation specifically. And you see other recommendations here, or other things you can do. I order the urine analysis and cytology, for example. There is no really defined or proven benefit to do this. And so some patients decide or opt out of doing that, but this is something you could do as well. I want to touch on briefly, because this is, I think, important. I'm sure you've heard of aspirin and for risk reduction or cancer prevention strategies for these patients. So I don't recommend people take aspirin yet, and this is mainly because aspirin is attached with a significant increased risk of side effects and complications like GI bleeding, especially if the patient's older or on other anticoagulation or other therapies. But aspirin in studies has shown to reduce the risk of polyps and subsequent cancers by 40%. So if you start at 10 times and you can cut that down by almost half, it's really something worthy. So we would really want to do this. And there is a study that's the CAP3 study here on the slide that will probably have results in 2025. That is measuring the difference between taking 100 milligrams of aspirin, 300, and 600. So if having 800 or 81 milligram, for example, or baby aspirin is similar in reducing the risk of colorectal cancer, I would probably recommend that for my patients. And then the 10 steps for cancer prevention, many patients ask about modifiable risk factors for colorectal cancer and other cancers. And so the American Institute for Cancer Research, AICR, has this really nice PDF that's 1 page that shows many important information about cancer prevention. And so I review this with patients. And one of the things we talk about for patients with Lynch syndrome specifically is reducing the processed and red meat intake. So pork, beef, hot dogs, bacons, and all of that. trying to add resistant starch or starchy types of food, either oatmeal, green bananas, or other things into people's diets, and to really try to have more veggies and fruits in their diet. And then reducing the amount of alcohol, because we know it's a cumulative risk with Lynch syndrome, so reducing the amount of alcohol people can consume. Onto the risk for MSH6 and PMS2 Lynch syndrome. So those are a little bit lower risks than the MLH1 and MSH2, but they're higher than the general population. So we kind of do the protocol, the screening protocol accordingly between the high risk and the general population. For MSH6, we do colonoscopies between 1 and 3 years. For PMS2, sometimes we'll stretch it a little bit more if the patient has had no polyps and no cancer history in the family. And then we continue that screening usually every 1 to 3 years, and we start at age 30 to 35. And we add the upper endoscopies between age 30 and 40, and usually every 3 to 4 years. People with MSH6, females, cisgendered females specifically, have an increased risk of uterine and ovarian cancer. So we focus our conversation on surgeries for these patients because their risk is much higher. And I think before I go on to talking about the risks for GYN cancers, I want to do a brief overview or conclusion on the GI cancer. So all genes are not created equal, and I would add all variants or all mutations in each of the genes are also not created equal. I have seen patients with mutations in FAP that don't have the same risks as others, so we pay attention to that a lot. And you can call a friend, a genetics friend, feel free to reach out to have interpretations of these results if you'd like. FAP is a high-risk predisposition to colorectal cancer and to other benign and cancerous tumors. And so these patients require a multidisciplinary approach from earlier on in their lives. Lynch syndrome is common, very common. Many of the cancers related to Lynch syndrome are preventable, and patients benefit also from this medical home. And then we do frequency of colonoscopies between every 6 months for people with FAP to every 2 to 3 years for people with a PMS2 or MSH6. All right, on to the specific updates for gynecologic cancers. And so this is where we talk about the risk of uterine cancer and ovarian cancers. So for Lynch syndrome specifically, the highest risk for uterine cancer is MLH1, MSH2, and MSH6, a little bit lower for PMS2. We can do screening with endometrial biopsies, usually starting around age 30 to 35, every 1 or 2 years. It works. We know we can actually do this, and we know when we do it, it works well, but this is not always done. Many women don't want to do this, and it's also there are not many physicians or clinics where this can be done well. And then when we complete childbearing, so when the family or patients complete childbearing, we recommend risk-reducing total hysterectomy. And then we add the risk-reducing salpingo oophorectomy, or the BSO, the bilateral salpingo oophorectomy for these patients, usually after childbearing is complete. The risk of ovarian cancer, and this is combining with what Dr. Nina Tan had talked about earlier for BRCA1, so the breast cancer genes, BRCA2, PALB2, other genes for breast and ovarian cancer, and the genes for Lynch syndrome. There are different types of pathology based on the gene, the predisposition that you carry. So people with a BRCA1 and 2 type of predisposition tend to develop the high-grade serous type of ovarian cancer, and people with Lynch syndrome tend to develop the endometrioid type or mucinous type of ovarian cancer, and that may have implications for treatment or prognostic. The natural history of how ovarian cancer develops is really unknown still today. There are some data on precursor lesions, but we don't know how long they are there before the cancer develops. We also believe it starts in the fallopian tube, which is why some patients do go for a salpingectomy initially and then the oophorectomy later. But today there is not enough data to say that's the recommendation, because we don't know for sure it works the same. Screening will show you the data is ineffective today. It's been ineffective for a long time. And so really the mainstay is risk-reducing intervention or surgeries save lives. So that's the one thing we recommend as the priority. And then briefly, because I've heard this from many, many patients before, 5 years of birth control has been shown to reduce the risk of ovarian cancer later on. So this is something for young carriers of these BRCA and other mutations to consider when they're trying to not be pregnant, but also to get some benefit for their long-term prevention. These are the lifetime estimated risks. I'm sure you've seen these graphs before. I put the average risk just to give you an idea of where everybody starts. And so for BRCA1, as we talked about before, it's really times 40 or 50 if you go up to the upper limit of the confidence interval there. So really the risk of having ovarian cancer with BRCA1 is really high, and it starts in the age 40s. For BRCA2, it's a little bit later, as you see in orange. The risk is up to 25%, so 25 times the general population. And for PALB2 and the other genes for ovarian cancer, the risk is between 5 and 15%. And for Lynch syndrome in blue, as you see there, there's a wider range because we need probably a lot more data. Now, I want to make a mention here that's important because I've heard this many times as well, is that there is no significant risk of ovarian cancer with ATM and CHEK2. So the recommendation is to not do risk-reducing oophorectomy for these patients because they don't need it, okay? This is data on screening. So this is one of the largest studies that were done in the UK. There are many other studies out there you can find. This was done on 100,000 women, age 50 to 75, and they really measured the difference between doing no screening for ovarian cancer, doing screening with transvaginal ultrasound and CA-125, or transvaginal ultrasound alone. And you see between 0 and 5, no difference. 5 years and 10 years, no difference in outcomes. And 5 and 20 years, absolutely no difference. So really, at the end of the day, doing transvaginal ultrasound twice a year with CA-125 may make the patient feel better, but has no impact on patient survival. So this is why we recommend salpingo oophorectomy, or RRSO, for these patients, usually between 35 and 40 for patients with a BRCA1, 40 and 45, as we talked about the difference in how early these cancer risks start, 40 to 45 for BRCA2 and 45 for PALB2 and others. We can do risk-reducing salpingectomy initially and then defer the oophorectomy, but again, we need a lot more data to prove that it is as safe as doing the oophorectomy, and it would be a really good thing to keep ovaries for people to not have menopause so early. One thing also that's really important for these women is when they go in for surgery, it is safe for them to be on hormone replacement therapy. And so usually the day of surgery, women are receiving their patch at the same time they walk out, either patch or estrogen therapy for if they've had their uterus removed, or estrogen plus progesterone if they have their uterus still in their body. And it is effective. So risk-reducing salpingo oophorectomy reduces all-cause mortality, so it saves lives and it prevents the diagnosis of ovarian cancer later on, really bringing that likelihood down to as close as 1% as possible. And if it's done before the age of 45, it has a second benefit for women. It does decrease the risk of developing breast cancer later on by 50%, which is not a small number. If you start at a risk that is 65 or 60%, if you can cut that risk in half, it's a really significant intervention. And then, so to conclude here for the part on GYN cancer genetic predispositions, ovarian cancer screening doesn't work, can be done to help the patient as they're kind of preparing to have surgery or just worried about a cyst that they had 6 months ago, but overall doesn't do the job in helping people survive longer. Risk-reducing salpingo oophorectomy saves lives, and that's the one recommendation we make most importantly for these patients. We can do risk-reducing hysterectomy and RRSO for patients with Lynch syndrome, and it's safe for patients to be on 5 years of OCP or birth control, and to be on HRT or hormone replacement therapy unless the patient has had breast cancer before. And I believe this is my last slide. So thank you very much.
Hi, my name is Dr. Bruce Montgomery. I'm a medical oncologist in genitourinary oncology at the Fred Hutchinson Cancer Center and the VA Puget Sound in Seattle. And it's my pleasure and privilege to be talking to you today about germline genetics considerations in advanced prostate cancer. And hopefully we'll cover enough information to make that all make sense to you. So a couple of things that I think are really important to consider is the fact that, unlike some of the areas that I think you've already heard about, the field of prostate cancer genetics is not ancient, shall we say. So we've known for many years that a subset of men with advanced prostate cancer developed their prostate cancer because they had an inherited alteration in one of the genes that you've heard about already, BRCA1 or BRCA2. But we really thought that that was a very small subset of patients dealing with advanced prostate cancer. And I'm going to talk to you a little bit about some work that we were part of in Seattle that was a little bit of an epiphany for all of us, because it showed that alterations in what's called DNA repair are much more common in prostate cancer than we anticipated. And about half of those alterations came about because a patient inherited a germline alteration from their mother or father that resulted in them developing advanced prostate cancer. So this is a schematic from the original paper that we were part of. This was a study in which about 5 centers participated, and we were looking to see if by sampling metastatic tissue that we could learn more about the genetics of prostate cancer. So ultimately about 650 biopsies were done, and many things were discovered about the genetics of prostate cancer. But the thing that was most immediately actionable, because of the things that you've heard on these previous talks, we already knew that some of these alterations could lead us to be able to treat patients differently. So when that study came out, this is a schematic from the first paper. The first 150 patients that were biopsied on that study, 20% of them turned out to have some genetic alteration that affected DNA repair. And as you can see in the schematic, BRCA2 was far and away the most common. So there's an array of genes on the right-hand side, all of them involved in DNA repair. And the thing that was actually perhaps even more interesting about this was the fact that if you look at the BRCA2 line, each of the large boxes represents an individual patient, and each of the sort of smaller boxes within each other, the ones that have the black diamonds in them are patients who inherited a germline alteration. That is, in their normal DNA, they had inherited an alteration from their mother or the father that was part of the inactivation of DNA repair. So this was a surprise to everybody who was looking at this data. And so one, we were very excited about the idea that we might have other treatment options for patients. But secondly, we were also very excited about the idea that perhaps germline genetics played a more significant role in the development of advanced prostate cancer than we had anticipated. So to follow up on that result, we engaged about 700 patients, and this was across the 5 centers that participated in that original study. And out of those roughly 700 patients, 12% of them had some inherited pathogenic or likely pathogenic alteration in a DNA repair gene, which means that it was in part at least responsible for these men developing their prostate cancer. So this was, a very exciting idea for a number of reasons. That's why it got into the New England Journal of Medicine. And it led us to understand a great deal more about how we can find alterations for patients that could lead to better treatment options. But the other half of this, which I think you've probably heard in the other talks, is that, if a patient's family doesn't know that the family carries one of these alterations, they can't do anything about preventing or catching cancer very early in its genesis. And so they're really at risk for problems. And if we find this in a man with prostate cancer, we can inform the care of the rest of their family, which I think is an equally important part of germline testing. So this is a table that shows you on the left these various genes involved in DNA repair, and then sort of somatic refers to the fact that the cancer, only the cancer has these alterations in it. And then germline tells you that the patient inherited a germline alteration that then also played a role in the development of the cancer. So, for example, in BRCA2, 10% of men have a BRCA2 alteration in their prostate cancer. Half of those can be detected by doing just germline testing. And the same holds true through all the genes except MSH2 and MSH6, where the frequency is a little bit lower in the germline alteration. But overall, taking all patients with advanced prostate cancer, germline testing can find these alterations that we can use to treat the patients differently about half of the time. And that's really, really important. And as I said, in these patients, the 25%, well, the 11% who have an alteration in germline, their families can also benefit from finding these alterations. So this is a schematic about how what's called synthetic lethality works. So repairing DNA damage in a cell is obviously critical, because if you allow DNA damage to exist, it's sort of the first step along the way to developing cancer. And so your body has evolved these multiple ways of repairing DNA damage. On the left-hand part of the slide, that's a cell that has multiple pathways that are intact. So any DNA repair, it can, or DNA damage, it can repair, and the cell goes on and lives just fine. In B, this is a patient who has, for example, an alteration in BRCA. So one of the pathways to DNA repair is knocked out, but the other pathway can take over and the cell survives. In C is a patient who doesn't carry a germline alteration of BRCA or an alteration in the tumor. If you give a drug that blocks this base excision repair pathway, then the cell can still repair DNA damage. But in the final slide, section D, this is a cancer cell that has an inactivation in BRCA. And when you give a patient who has one of these alterations this inhibitor of the PARP1 enzyme, then the cancer cell cannot repair DNA damage, and even cancer cells cannot survive with sort of limitless DNA damage happening. So this is a way in which these inhibitors of the PARP1 enzyme can actually be used therapeutically. And that is an approach which is used in patients who have underlying BRCA and other DNA repair alterations. So this is a schematic just to show you how significant these findings are. So this was from the original study that led to the approval of PARP inhibitors for patients with prostate cancer. And on the left is what's called progression-free survival. And this line represents the patients who were treated with a PARP inhibitor. And these were the patients who were treated with the standard of care. And you can see there's a very significant difference between those two groups of patients in terms of benefit. And on the right-hand slide is the overall survival curves, which also show you that the use of this class of drugs in patients who have these alterations, which can, for example, be due to a germline alteration, can have improved survival as a result of treatment with a PARP inhibitor. So that's a very important consideration for us in terms of treating men with advanced prostate cancer. The second area that was covered in some of the earlier talks is this idea of what's called mismatch repair. So it's a different type of DNA damage repair that works through different genes, in this case, 4 different genes that are part of the Lynch family of genes. And so the idea here is that these types of alterations can result in many, many, many genetic mutations in the genome of the cancer cell. And in principle, your immune system can recognize one of those genetic alterations. And because there are so many of them, the likelihood of your immune system picking that up and being reactive against that specific alteration is much higher. And that has obviously a lot of therapeutic potential benefits. So we're in the age of immunotherapy, where we can sort of ramp up a patient's immune system to recognize cancer as foreign. And in these cancers, the ones that contain these many, many genetic alterations, the likelihood of benefit is significantly higher. So These are schematics. The one on the left, which with the title over the top of it, is from the original study, about 260 patients with mismatch repair deficient tumors of many different types. Only 2 prostate cancer patients were in that group. But what you can see is that out to 3 years, about half of the patients who were treated were doing fine. And those patients, we know from subsequent follow-up, the vast majority of them were cured of their metastatic malignancy, which is just not something that we have the opportunity to do often enough in oncology. So because there were only a limited number of patients in that group that had prostate cancer, we did a separate study looking at our patients at a couple of different institutions, including the University of Washington Hutchinson, and essentially showed that patients with prostate cancer also benefit in exactly the same way. And I have a number of my own patients who have been cured with immunotherapy. But if you don't find these alterations, you're never going to be, this is not a standard of care approach in patients with prostate cancer. So you're never going to be able to treat a patient and cure them unless you know they have an underlying alteration. So this is a really important genetic alteration to be looking for. So currently in the FDA approval space in advanced prostate cancer, there are 2 sort of general areas: patients who have metastatic disease that is resistant to hormone therapy, but has not been treated with the next generation of drugs that we use to treat advanced prostate cancer. And then the lower level are the patients who have been treated with these next generation agents, but then can be treated with a PARP inhibitor alone. And I'm not going to go through each of these individually, but suffice it to say that a germline, or meaning again inherited, or a tumor-only alteration in BRCA1 or BRCA2 is an indication for all these different agents. Obviously, many companies felt that this was an approach that made sense, and we're very lucky to have these options. And then on the bottom is pembrolizumab, which is an immunotherapy drug, and that is indicated for patients who have microsatellite instability, high tumors, or mismatch repair deficiency, or just a high mutational burden. And those are patients who can really benefit, as I said, from the potential that immunotherapy will activate their immune system against the malignancy. So who do we test for germline alterations? So men with metastatic prostate cancer are a broad indication. So every man with metastatic prostate cancer should be tested for the presence or absence of a germline alteration. The guidelines also recommend testing in men with what's considered high risk for relapse or very high risk for relapse prostate cancer that hasn't yet spread. So that means clinical T3, which means the cancer is getting out of the prostate, or a high Gleason score of 8, or a PSA of 20 or above. And those are the 2 main groups. There's a lot of granularity to the next 3, which is really the domain mostly of genetic counselors and other folks. But the idea being that if you see a patient who has what to you sounds like a very compelling family history of malignancy, then, and or a history of male breast cancer, then making sure that they've been referred for genetic testing is, I think, part of standard of care. So, and then finally, the thing that I want to emphasize is that even though we have made progress, we clearly have a ways to go. So that's the area of research where we're trying to improve uptake of testing. And so, for example, education is something that the more providers know, the more likely they are to take advantage of what's available and get their patients tested. So we have developed a course through what's called the City of Hope, which is one of the best genetics courses in the country. We've been developing that for providers in a number of different medical systems. We've developed patient videos so that patients are better educated about why they should have testing done. That's also obviously an equally important part of the equation. And then patients who don't live, for example, in an urban area. Let's talk about Seattle. That's where we are. You know, if you live east of the Cascades, the density of medical care is significantly less, and your access to care is also significantly less. And as a result, those patients clearly do not get tested at the same rate as they do if they live in an urban area. So we're looking at different ways of reaching those patients, making it possible to test them remotely, usually through what are called saliva kits. And then we're also making access available just through a website where patients can go in and actually essentially order their own testing. And we're identifying patients and reaching out through cancer registries and other databases. So then the final thing is you really need to approach patients based on who they are and where they come from. So clearly people come to medicine from different perspectives that lend themselves to different approaches to education and initiation of this kind of testing. So I think these are things that we're doing, trying to improve uptake of testing, but I think the overarching message is clearly, if you have a patient who has metastatic disease who you don't think has had testing done, then having a conversation with their oncology provider or, if you're comfortable with it, referring for genetic counseling and testing is really in their best interest and clearly standard of care. So I think with that, I'll hand off the discussion back to Katie Stoll to talk about CME credits.
Thank you for viewing this session, Updates in Cancer Genetics, Personalized Treatment, and What You Need to Know from Oncology. Speaker bios, as well as links for other sessions in this 5-part series, can be found on the Washington Medical Commission website. You will also find a link to the webinar evaluation. Please make sure that you complete this evaluation as it is required to receive CME credit. I want to thank all of our speakers again for taking their time and providing their expertise as speakers for this session. And I want to thank all of you for taking time to view this CME opportunity. Thank you very much.